Institutes of Health. She's a professor of neurology at the University of California, Los Angeles, UCLA, the director of the UCLA MS program, holds the Jack H. Skirball Chair in MS Research, and is the faculty neurologist for the UCLA Comprehensive Menopause Care Program. The Voskuhl laboratory does bring cell-specific and region-specific transcriptomics, that's a new word for me, comparing females versus males, as well as young versus old ages, to discover neuro-protective treatments for women and men during aging and MS. Dr. Voskuhl sees MS patients in the UCLA Neurology Clinic and healthy women with cognitive issues in the UCLA Comprehensive Menopause Care Program. Her clinical research focuses on tailored estrogen type, dose, and timing to prevent MS disability worsening during menopause. As the lead inventor on over 15 UCLA-owned patents in the U.S. and Europe, she works to provide assistance to underserved women with cognitive issues during menopause. Welcome, Dr. Voskuhl.
Thank you. Thank you for having me today. I'm honored to follow Dr. Bove. She's done some tremendous work in this field, and I'm going to shift gears quite a bit from pregnancy to menopause. And so these are my disclosures. Let's see. There we go. So that's the title of my talk. I'm going to really talk not just about menopause, but also HRT. And fortunately, the new interest really in trying to optimize an HRT for women during menopause, that considers the brain, an important aspect. So these are my disclosures. The most relevant is the patents licensed by Cleopatra RX. And what I'm going to talk about today is when I started thinking about working on MS and menopause, it really came from a point where I had done MS work for over 2 decades. And just, I think to understand menopause and MS, you also have to spend time really just doing menopause alone. So MS by itself, menopause by itself, and then if you put those two together, then you'll actually be able to understand this complicated situation of menopause and MS together. I think you have to understand them each individually before you can understand them when they're together and even more complicated. And so I set out on a mission to understand menopause in otherwise healthy women as a backdrop for trying to understand menopause in MS. To that end, as was mentioned, I've been for over a year now the faculty neurologist for the Comprehensive Menopause Care Program. What is that? That's a program where the GYNs have started it, and they have a core group that then brings in an expert on, because menopause is a multi-organ system problem, they bring in experts on bone, breast, brain, which is me, etc. So it's a really interesting program, and it's really rewarding for the patients to be able to see people with expertise in each area. And of course, with my focus on brain, it's been great seeing all of these patients that are otherwise healthy and they have menopause, so I can learn from that and just imagine what's this going to do to MS based on the decades of experience there. So to that end, and consistent with that outreach and broadening of what I do, we presented this work not only at the American Academy of Neurology, which you would expect because of MS focus, but also at the American Academy of Gynecology and the North American Menopause Society just in the last few months. So again, as I said, let's start to talk about the effect of menopause in healthy women so that we can learn about what it may do, and you can start to expect some of the things you may see with menopause in MS women. So to review that, again, menopause is deleterious for multiple organ systems, including bone and uterus, breast, just maintaining youth and health as a woman. When one loses estrogen, it is a bad thing. And again, it's also bad for the brain, to no surprise. What's been described for literally decades is the fact that women say they're in brain fog. This is a term for cognitive difficulties with menopause. Now, this is not just subjective, and it's not just layman's terms. It's more than that. It's actually been shown very clearly by neuropsychologists that certain cognitive domains are affected during menopause in healthy women, and that is verbal memory, some processing speed, these things are very well documented by neuropsychologists. They can do formal testing and they can see the level at which they there are deficits and when they actually come into play, at what years. Now, notably, this is not IQ. This is not global cognition at all. What it is, as I said, they are very specific domains of certain things that they'll describe. I see them every week, and they say they'll describe what they're having trouble with. They can't think of words. They walk into the room. They don't remember why they walked in. They will have trouble maintaining a focus and a concentration, unlike when they were younger, they can't do it. And so it's very concerning to menopausal women. This is otherwise healthy. And so many people said, well, they are just not getting enough sleep because they have hot flashes and night sweats and they have mood changes. And I'm not saying those things don't play a role. I think they do. But I don't think that's all there is to it, because in menopausal women, those hot flashes go away naturally within 3 to 7 years, and the cognition doesn't improve and is resolved back to the way it used to be with that. So it's more than just not being able to sleep. There are cognitive domain specific problems, and this can even be more clearly emphasized or underscored when one thinks about MRI. So when people have done large groups of patients that are otherwise healthy and they undergo menopause, either surgical or natural menopause, so when the ovaries are removed surgically or they just undergo natural menopause, in both situations, the MRIs of these women, when you look at them across in a clinical research plan, what happens is there are areas of the brain, namely it's called hippocampus and frontal cortex. Those are just words for a particular part of the brain that is involved in, lo and behold, these cognitive issues that tend to be problematic. So these areas are undergoing atrophy with menopause. The other thing is that not just atrophy, but other thing on MRI, which is functional connectivity. That's the ability of one region of the brain to speak to another. This is also impaired with menopause. And again, just to underscore, this is not global brain atrophy. It's not global changes. There are region changes that align with the cognitive specific disabilities that are occurring. So it's a very cognitive domain specific, and it's a very region specific problem. I'm going to emphasize that because I want to revisit what's been done with some of the HRT studies before, or not done, I should say, with respect to cognition and why that's so problematic and how we have to overcome those previous ways of looking at things. So it's a very specific problem during menopause. There is a brain problem, and it's very specific, and it's very significant. By the way, it's 50 to 70% of menopausal women who get cognitive issues at some point. 50 to 70%. Otherwise healthy, cognitive problems with menopause. So it's very, very prevalent, and it needs to be addressed rigorously and specifically. Now, when we think about neurodegeneration, my lab is focused clinically and preclinical models on MS, aging related to menopause, and also we're studying Alzheimer's. And so the thing that's really interesting about neurodegeneration and all of these conditions and how aging overlays, which is basically how menopause overlays the loss of sex hormones, is very interesting. So I don't know if my pointer shows up here. There's all assuming it doesn't actually. What's interesting about aging is that testosterone is in blue. It drops by 1% per year from the age of 30 to 70. So it's a very gradual loss of testosterone and andropause in men. In contrast, of course, when women undergo menopause, the average age is 50. The range, of course, perimenopause can be anywhere from 48 to 52 or 3. It's very abrupt. So women do very well for quite a while, and then at the age of menopause, estrogen drops abruptly. And so this is when these neurodegenerative conditions, it's very easy it's easier to see in women because it's so abrupt, this loss, as compared to men. Why do I make them an analogy? Because testosterone is converted to estrogen in the brain. And so there's evidence that both testosterone and estrogen can be neuroprotective. The difference here is the timing of which they're lost with andropause and menopause. Now, that said, with women, there's a real opportunity here because for trials or any kind of clinical studies, if you have something that happens over a year or two and it's so abrupt, like the drop in estrogen is with menopause, it actually makes it very amenable to fixing it because you have a window whereby things have changed dramatically. Again, if you're trying to fix andropause, it's happening over so many years. Those trials are not feasible, but boy, they really are with menopause. So it's actually an opportunity that it's bad that it happens so abruptly with women, but it's actually an opportunity to help fix it. But it hasn't been fixed yet. And why is that? Because estrogens are complicated. Estrogens are not alike. The types of estrogens vary. So Premarin, which you probably heard about with menopausal treatments before in decades ago, it's a low-dose mixture of various types of estrogens. And when I say types of estrogens, I'm referring primarily to estradiol, which is the gold standard estrogen. It's there in the menstrual cycles. It binds very strongly to estrogen receptor alpha and beta. Alpha was the first discovered. That's why it's called alpha. Beta was the second. That's why it's called beta. There are two receptors, alpha and beta. This is going to be very important for both efficacy and toxicity of estrogens when you try to treat menopause. As I said, estradiol, the gold standard, it's very strong. It was discovered first. It binds alpha very strongly. Estriol is an interesting estrogen because it's actually the estrogen of pregnancy. And that's why I got so interested in it, was because of this French group from 1998 that Dr. Beauvais showed the slide of, where they showed this dramatic reduction in relapses during pregnancy, the late pregnancy. So estriol goes up, is not detectable when you're not pregnant, and then it's very low the first trimester. It goes up some the second, it's very high in the third trimester. So it really aligns with that improvement in MS during the third trimester. That really starts to bode well for something that could be anti-inflammatory and neuroprotective. And so we focused extensively on estriol. Some people said, well, why are you doing that? Well, estriol is such a weak estrogen. And actually, it's weak for estrogen receptor alpha, but not for beta. It binds ER beta primarily. That's going to be important for safety. So what about efficacy for the different estrogens? Well, there's no evidence that Premarin, this mixture of a low-dose estrogen, the different types of estrogens that are in Premarin, would be neuroprotective. That said, when you look at the other two estrogens, both estradiol, which binds strongly to ER alpha and also beta, as well as estriol, the one that is unique to pregnancy and binds primarily ER beta, there's a tremendous evidence that both of these can be neuroprotective at the preclinical level and now at the clinical level as well. So another element that's important is not just any dose will work. So with estrogens, when you take neuroprotection, higher doses work better than low doses. And you've got to be compliant because your blood levels will drop. Now, why is that so critical? Because estradiol, which is the widely used estrogen for hot flashes, it's the one of the menstrual cycles, it's the one that binds strongly to estrogen receptor alpha. The problem is estradiol binds strongly to ER alpha in breast. And breast cancer is extremely common. It's 1 out of every 8 to 10 women. And so all the GYNs are very, very concerned about treating for longer, very long at a very high dose with estradiol. They generally limit it to 3 to 5 years at the lowest dose possible. So with estradiol, the treatment needs to be the lowest dose possible for the shortest duration possible. And what they use it for, what it's FDA approved for, is hot flashes. It's not been approved for cognition in menopause. Nothing has been approved for cognition in menopause because no one has studied it well. The second estrogen I've been interested in, because of the concern of binding to ER alpha in breast, is to focus on this pregnancy estrogen called estriol. And the reason is because there's publication evidence of neuroprotection, and I actually really like that it binds weakly to ER alpha in breast. So let's talk about some of those past studies of hormone replacement therapy in menopause. They originally, decades ago, were using Premarin. Again, it's pregnant male urine proteins, as I said, a low-dose mixture of a lot of different estrogens. And they also used, then the next wave was to use this estradiol, which is this very strong estrogen that binds to ER alpha. Now, those trials were designed to, this is a clinical trial design issue, which I like doing clinical trial designs. It's interesting when you look at how those old studies were done. They were designed to see if they could cause a reduction in hot flashes. And indeed they do, and they were FDA approved to reduce hot flashes. They also, estradiol works well for osteoporosis. There was also reason to believe they could help for cardiovascular, and it didn't reach significance. So they weren't FDA approved for that. What they were not designed for, the trials were not designed for, was to test the effect of those things for cognition. even though it's widely known that 57% of women have cognitive issues, it was ignored. The only thing they did was, after the trials were over, they did what's called exploratory outcomes to see, oh, well, after it's all done, did those treatments affect global cognition? And by that, I mean, did they have dementia or not? And with the dementia, they didn't even specify whether it was Alzheimer's dementia, vascular dementia, or mixed dementia. So this was, again, this isn't what happens during menopause. They're not getting dementia. They're not getting, as I said before, it's not global IQ. This is not what's happening. So they're measuring after the fact, not designing it for an outcome that is really not relevant. The other thing, if they did MRIs at all in these studies, the old HRT studies, if they did the MRIs at all of the brain, when they did them, what they looked for was global brain atrophy. And as I said before, that's not what happens during menopause. So clearly, I've written this in various forms and presented it. Clearly, I believe, of course, what's necessary and logical is that the primary outcomes needed in these trials are not global cognition. It is these cognitive domain-specific outcomes that we know are affected during menopause, namely working and verbal memory, processing speed, and so forth. What we know the neuropsychologist is affected during menopause, those should be the primary outcomes for these trials to determine whether they succeed or fail. The second thing that should be used would not be to look at global atrophy. It would be to use atrophy of these very specific regions, hippocampus and frontal cortex, just names for these regions that align with these cognitives that are known to be affected. So this is a trial design issue that needs to be applied to what we know. So what we did when we started thinking about trial designs and doing major trials like this, you have to have a lot of preclinical data that this works. And so we went to a mouse model, and this is a Nature Communications paper from last year. We also extended on that and presented additional findings actually last week in Chicago at the North American Menopause Society. So what we showed was extremely informative for what happens during menopause with respect to neurodegeneration. And that is the following. So what we did is we took mice that were either young, midlife, or old. And we asked, what is the amount of atrophy in this brain area that serves cognition? And so what you see in the graphs on the side are the middle one in particular. This is dorsal hippocampus. It's the volume of this. It's the volume of this region known to be associated with working memory. And the slashes are the mice who had ovarectomies. So we gonadectomize them. It's take the ovaries out. And the ones that are not hashed are the ones that have their ovaries intact. What you find is that, first of all, when you look at the intact mice, they do have a drop in this volume from going from midlife to old age. What's really interesting is when you add on to that, taking the ovaries out, the midlife ones have a volume as low as the old age. This is very, very important because what that means is that when you combine midlife aging with loss of estrogen, it creates more brain atrophy in this cognitive area. So the next question that we asked was, well, that's fine, you see atrophy in that brain region. What about cognitive testing of these mice? And so what we showed here was we compared testing in young mice and midlife mice. This is really interesting. So when you take the ovaries out in these young mice, it really doesn't do much. If you look on the left, the red hash marks are no different than the solid bar that's red. It's no different when you just take the ovaries out, but they're young. But look what's happens right next to it when you take the ovaries out and they are midlife. So that they basically have a cognitive problem, that bar's lower. The same thing happened when you do another test, which is it's spatial, so can you recognize going into a target quadrant versus another quadrant that you shouldn't be walking into? So yet a cognitive test showed that when you take the ovaries out in a young mouse, it doesn't have much effect actually. And when the mice get older but still have their ovaries, it doesn't have much effect. But the problem is when you combine those two, you start to have cognitive issues. And then on the right side of this slide is where we correlated that time in the target quadrant, or the ability to remember, with the volume of that structure we just showed. And those correlated together. So then on the next slide, what we did is we did pathology, and we said, what's happening in this area of the brain that's undergoing this atrophy, and it's aligned with having cognitive issues. And what we found was we looked It's called glial activation. Glia are cells in the brain that are supportive. They can be inflammatory. And what we found was, once again, at the pathology level, looking at that critical brain area that's affected during menopause, what we found was that these cells, when we did take the ovaries out in young mice, it didn't make that much difference. But when we combined taking the ovaries out with midlife aging, lo and behold, we saw this really robust inflammation going on. And that's the bar graph to the far right where it says midlife, and it's got the hash marks. That's the midlife that have had the ovaries out. On the lower right, you see the opposite, where it's a decrease, and that is, unfortunately, synaptic loss. So two things that happen in the brain with aging and are accelerated with menopause are these supportive cells get activated, and they're call them inflammatory, but it's a little more complicated than that, but they get activated. And that is associated also with synaptic loss. Synapses are the connections between the nerves in the brain that make signals go from one to the other. This is how signals are transmitted and conducted across the brain. So when you lose these synapses in this area, it's very important. So what we show is that when you combine, this is called a sex hormone by age interaction. So the combination of losing estrogen with getting to midlife aging is bad for the pathology of the brain by causing these immune cells, the resident immune cells, to be activated and having those synaptic connections lost. This is just a schematic of the different cells I was referring to. I think it's interesting for all of us to kind of think of these synaptic connections, and especially with MS, to think about it, electrical. It's really easy to think of it like as a plug, where you've got a wire with rubber on it, and you stick it into a plug. That's what the electrical impulse goes through. The analogous would be in the brain, where you basically have these connections. The plug is kind of where the synapses are. The rubber wire on the rubber around the wire is the myelin, and when you strip that off, the wire doesn't conduct as well. These are really interesting. It's an interesting analogy to make to really understand this process, where you've got to have those connections. You've got to have that wire. You've got to have it covered with the myelin. This is what it takes to have these connections. Now, if you look over to the right, you can see that do you see the blue cell? That's the neuron, and then its branches, the axon, and you see this connection where it's kind of these bulbous things that are coming together. That's the synapse. So with MS, we're all concerned about myelin, and that's the oligodendrocyte, which is the purple one that's basically making these connections and laying down the myelin around that axon, that branch of the nerve cell. So what we wanted to ask was, well, we know that when you lose estrogen during menopause, you have loss of these synapses. So we wanted to know the mechanism, because if you know the mechanism, you can fix it. So what we said, well, let's let them have let's do something not so dramatic as taking the ovaries out and having them then go into the surgical menopause. Let's let these mice have their estrogen. And I'm going to get to the people in a minute, but we have to have the mechanism first before we can treat it. So let's let them have their estrogen. We're not going to take the ovaries out. But what we're going to do is we're going to have genetically knock out that estrogen receptor beta. The receptor I said that is a great target because it's not going to affect breast if you target that one. So we're going to knock out that estrogen receptor beta to see if it has any effect on just that cell in the blue, the neuron, the main cell, the blue cell, the neuron. You see its branches, it's getting myelinated, it's having these synapses. We're going to knock estrogen receptor beta out of that and see if that has an effect. So it's like a really micro. You're just taking that one receptor out of that one cell in the brain to see what happens. And the other cell we became very interested in is this green cell. That's called the astrocyte. Actually, it makes the multiple sclerosis is named sclerosis because of sclerotic plaques made by astrocytes. Astrocytes are very big. They become activated in MS. And so even in this menopause model, we wanted to knock that estrogen receptor beta out of either the blue cell, which is the neuron. You'd think that would certainly have an impact. Maybe. It's a hypothesis. Who knows? But also as a contract, what if you knock the estrogen receptor beta out of this astrocyte, this green cell that's a supportive cell for the synapse? So we were very surprised to find, you never know till you do the experiment, and we'll never know if the slide doesn't change. It's not changing on mine. I'll click it again. Okay, it went two of them now. Okay, there we go. So again, We were surprised to find that when you look over on the left, this is the cognitive testing. The red is where we've not knocked any receptor out. They still have their estrogens. Everything's great. You've got this target quadrant and other quadrant. You see that separation. These mice know where to go. They've learned. They've got memory. Actually, look at the one all the way over to the orange one. It's still on the graph on the left, but it's the orange graph. That's interesting because that's when we knocked that estrogen receptor beta out of neurons. It made no difference. So when you're taking the estrogen away, the fact that it doesn't bind that receptor in the neurons, it actually doesn't matter because you can knock it out of that cell and it doesn't matter. But where's the money? The green one. So if you look at the green one, that's when we knocked the ER beta out of that astrocyte, the supportive cell. When you don't get stimulation through estrogen receptor beta of the astrocyte, you have a problem. They can no longer distinguish the target quadrant from the other quadrants. They can't remember what they've learned. By the same token, if you look at the middle bar graph, this is the atrophy of that area of the brain associated with menopause, associated with cognitive decline. Same thing. When you look at the red and the orange, the ones that have all the receptors, the red, they're doing great. When you look at the orange, when you knock the estrogen receptor beta out of the neuron, they're doing great. But look at the green one. Now they've lost volume. They've got to be. That's because you don't have estrogen receptor beta stimulated in these astrocytes, that supportive cell in that region of the brain. And lastly, on the right, it's the same thing with the pathology. It's all mediated through the astrocyte, the glial activation, synaptic loss. So then what my lab does, we also do genetic analysis. So we say, okay, this astrocyte not getting this estrogen in this part of the brain seems to be the problem. It's the problem really when female or women are midlife, aging, in addition to losing estrogen. What are the genes on there? And we can do this by whole genome-wide transcriptomics. What that means is you're looking at gene expression in this particular cell in the presence or absence of this estrogen receptor beta stimulation. And what we found, again, was very interesting and surprising to some degree to me. We found that when you don't have stimulating this particular cell through that receptor, there's a problem with it's called gluconeogenesis and glycolysis. What is that? That's glucose utilization. It's utilization of sugars, energy for the brain. And there was upregulation of this gene that's highly involved in this shift from being able to use glucose properly versus improperly. And if you look over to the right, we're going to go from mice to people. So now when you look over to the right and you see the red where it's a high bar and a low bar, that is women, menopausal women that don't have MS. We're going to get to MS in a minute. This is menopausal women, and they're either over 60 or less than 50. So they're menopausal or not menopausal. And what you find is this same gene associated with a problem with glucose utilization is increased in the brain of menopausal women. We then showed a correlation between this protein being increased and age. So clearly with age and menopause, particularly at menopause, this protein is going up. And it reflects a problem with glucose utilization. Now, why is this so important? Because there's been a lot of studies actually that have been talking about glucose utilization problems in the brain during menopause in women. And a lot of this is picked up by PET scans. It's early Alzheimer's disease. It's menopausal women. And this is the pathway that I'm showing, the shift from for the more scientific glycolysis to gluconeogenesis, shifting back and forth, and this problem that's happening. And now what does it show? We've identified the cell that's doing this. It's the astrocyte. Through the studies I said, we knocked this receptor out. So now the biologic substrate for why this is happening, you're having glucose utilization problems in the brain. It's like like Roberta Brinton has done a lot of work in this. She says it's like the menopausal brain is starving. It can't use glucose. It starts to burn fats and amino acids. So it's a real problem when the brain starts to shift. She thinks it's even an equivalent to some of the hot flashes that are being experienced is a sign of that. I don't know about that, but I'm just saying I think she's right now because we identified that it's the astrocytes that is where this is going on, the cell of interest. So all that, to what end is that? To what end is we can reverse it now. And so what we did is we treated these midlife mice that had their ovaries removed, and we treated them with estriol, which is the naturally occurring estrogen of pregnancy. And we also treated with a novel estrogen receptor beta ligand just to affirm it's just stimulating that receptor. In both cases, we saw that this protein associated with poor glucose utilization went down to normal when they were treated. And in addition, the cognitive function, which was impaired with ovarectomy, it was restored when we treated with either estriol or estrogen receptor beta ligand. So the conclusions of this basic science is that there's a sex hormone to understand menopause, and we're going to now apply this to MS, but to understand menopause during aging and why it's a problem is because there's a sex hormone by age interaction. It's a combination of having both estrogen loss and midlife aging that is so bad. And what do I mean by bad? As a summary, it means cognitive difficulties, atrophy of areas related to cognition, as evidenced by MRI, and neuropathology of that region. This is mediated by estrogen receptor beta in the supportive cell called an astrocyte. What does it do to it? It interferes with proper utilization in the brain. And this can be treated with either estriol, the estrogen of pregnancy, or a novel ER beta ligand to reverse these problems with cognition. So, back to the summary slide. We now have a possible treatment for where the red line drops so abruptly at the average age of 51.5 is menopause. When it drops so abruptly in women, we can't just let them go without their estrogen and give them something that will stimulate ER alpha strongly in breast. They're scared of it. They should be scared of it. It can't be given long term. So we can give an estrogen that binds estrogen receptor beta. The beauty of estriol, the estrogen of pregnancy, it's actually already been given throughout Europe for over 40 years at a dose of 2 milligrams and has been shown to be safe. So there's a vast post-marketing experience in Europe and Asia to give estriol, the pregnancy estrogen, at 2 milligrams a day, and it's safe. So this is extremely exciting to try to now see if this can prevent cognitive issues of menopause. Finally, something that can be build a registry and get that. And the next slide is going to clinical practice. So again, the problem here is, I'm going to MS next, I promise, but you really need to understand, even for healthy women, what's going on with menopause. So 70%, up to 70% of women with menopause have cognitive issues. There's currently no FDA approved, no EMA approved treatment. It's because it hasn't been studied in any depth or detail like it should be. It's a major unmet need in ultimately half the population. The good news is that estriol, the estrogen of pregnancy, targets estrogen receptor beta in brain. And the good news is it binds weakly to ER alpha in breast. There's decades of safety in Europe and Asia using a 2 milligram dose for hot flashes. And this can be given in women ages 45 to 65 using the usual contraindications to standard HRT. To that end, that's what the patents that were discussed, that's the ones I am an inventor. The UCLA owns patents for giving a certain dose, type, timing of estrogen with a matching progesterone, and a company licensed it called Cleopatra RX to put it in a blister pack. Like a birth control pills for women, that's for menopausal women, like they do for young women, they get birth control pills where they're changing estrogens and progesterones, they're optimizing them for birth control. This can be done for menopausal women so that they get the estrogen and the progesterone they need for menopause. And of course, what we're trying to do is to now follow cognitive outcomes and also, of course, use standard safety outcome measures for HRT, which have been well established previously. MS. We finally get to MS, which I know you guys are waiting for, but I think this is a really good backdrop. And some of you may have friends who don't have MS, and they're concerned about menopause too. So with MS, it's even more complicated. And so let's talk about MS, which I love. I don't love it, but I think the patients are fantastic, and I think we've made major inroads, and I think we're ready to make more. So with MS, you know, women are extremely important. I mean, women are, it was 2 to 1, now it looks like it's 3 to 1 incidence of MS in women as compared to men. So it's very prevalent in women. And as Dr. Beauvais said, and as has been described since the French group since 1998, pregnancy is very protective for MS. Lo and behold, that's when estrogens, both estradiol and estriol, to be fair, both of them are very high in that last trimester, this time of protection. Conversely, menopause is a time when estrogens are low, and that also aligns with neurodegeneration. Let's talk more about that. The effect of menopause on women with MS. We went over the effect of menopause in women with MS. Now let's talk about the effect of menopause on women with MS. So with respect to MS women, they have said for a very long time that on questionnaires, subjective reporting, MS women have said that their pre-existing disabilities seem to get worse. And they've been saying this for decades. Fortunately, longitudinal studies were then done by Dr. Bove and by the group, well, really it's both Harvard and UCSF, really nice studies, finally, collecting longitudinal objective data to actually ask whether disabilities are worsening. Again, these were not prospective studies. They were basically patients anyway, and they're examining them every year or so. And they are starting to detect some signals that indeed there is some objective disability worsening with menopause. And this is a real shame. I mean, it has to be addressed. Anyway, the last thing which I wanted to really point out was Jennifer Graves at UCSD, really nice study where she looked at MRIs in women who were really young perimenopausal. They were 42 to 45. They were looking at a biomarker for menopause. It's a lab test, so very Mullerian hormone. But those changes, even in early menopause, were associated, that menopause is coming, were associated with worsening in disabilities and worsening in cerebral cortex atrophy. So again, this localized atrophy. Does this sound familiar? Yes, it does. We're talking about specific disability worsening, and we're talking about localized atrophy, not global atrophy, but localized cortical atrophy, now with menopausal women with MS. So losing estrogen is bad for MS women. Now, how do we fix it? So when you think about MS, you can think about cognition. Cognition is affected in MS, and we've done that using the preclinical models, and we've shown that estrogen can be protective in the model of MS with treatment. But we also did more studies, and that was, of course, in areas that would affect walking. So walking and motor ability is so important in MS that we did studies also in spinal cord to see how is estrogen protective, or can it be protective in the MS model. And then we did trials in MS. But what I want to talk about first is this, and it's a short summary, but in this MS model, to first study using two different MS models, actually, when you look at the white matter where you're seeing demyelination and axonal damage, some of these things you've heard of before, it's again, the blue cell and the axon going to the synapse. When you look at that and you ask questions about, is there a problem in the spinal cord with respect to not having estrogen, what we did is we looked at both, we looked at estrogen receptor beta and its role. And we're going to focus in the MS studies in spinal cord because everybody's concerned about walking disability in MS. And we're also going to focus on another cell I haven't talked about yet, which is the orange cell. It's called microglia. Why are microglia important in MS? It's because they are the resident immune cell of the brain and the spinal cord. So they're kind of like macrophages coming in from the blood, but this is the microglia are a cell that's been there all along. They're inherent to brain and spinal cord. They're very important for remyelination and repair in MS because when microglia are activated and inflamed during MS, they inhibit that oligodendrocyte, that cell that makes myelin, from remyelinating. That's a problem. So now you're having the myelin or the rubber off the wire stripped off by angry macrophages coming in and stripping it off from the blood, coming in and stripping it off. And you can't repair because your oligodendrocyte, the purple cell, is not making myelin. And one of the reasons they're not making myelin is because that orange cell is inflamed and it's preventing them from doing it. So what we did when we looked at estrogen treatment and the estrogen receptor beta, to make a long story short, a lot of papers, to summarize it, is if you look at these arrows, what we showed is that when we stimulate with estrogen receptor beta in the MS model in spinal cord and other white matter tracts deep in the brain, We found that you can stimulate myelin repair, remyelination, when you treat with the ER beta by affecting the oligodendrocyte directly so that it makes more myelin. And also, it's a two-pronged approach. It works on this estrogen receptor beta in the microglia to stop this inflammation from inhibiting the remyelination. So it's a two-pronged approach to enhance repair and remyelination. That results in healthier axons, the extensions of the neurons, and actually synaptic plasticity and increasing those number of synapses. So this is in the MS model. So of course we translated that to clinical trials of estriol in MS women. This actually was not done in menopausal MS women. That needs to be done. This was actually done in MS women to see if we gave them a pregnancy dose of estriol, like the third trimester, could that be protective? So I didn't put in here our early study in the Annals of Neurology where we showed that there was a modest anti-inflammatory effect. What I'm going to focus on here is neuroprotection with estrogen, and specifically estriol, the pregnancy estrogen in MS women. What we found in several papers was that when we stimulated with an 8 milligram dose, this is higher than the dose used in menopause throughout Europe, which is 2 milligrams. We used an 8 milligram dose, a pill a day at 8 milligrams to induce a blood level that was equivalent to about mid-pregnancy in these MS women. What we found was, number one, an improvement in cognitive processing speed within 12 months. This was as compared to placebo. This is in a phase 2 clinical trial, so it was randomized and controlled. The second paper we found was that there was not only an improvement in cognition, there was a reduction in cerebral cortex atrophy in the estriol compared to the placebo, again at 12 months. The third paper was we found that there was also in the estriol treated compared to the placebo, there was a reduction in a biomarker of neurodegeneration called serum neurofilament light chain. It's been widely used around the world as a marker for neurodegeneration. We showed a reduction in marker in estriol compared to placebo within 12 months. And lastly, just to show a relationship as well, we showed that improvement in cognitive function correlated with higher estriol blood levels. As I said, estriol type, dose timing, as well as dose. These things all matter. Neuroprotection is not easy, and you have to treat with the right dose, the right type, etc. So the bottom line is these studies in MS have shown the preclinical data and the trials are showing that we can design an HRT for neuroprotection, not for hot flashes and all about these other things. It can do some of those things, but my goal as a neurologist is to design something for neuroprotection and to prevent disability worsening during menopause. And the nice thing about this is we're finding something that can bind to estrogen receptor beta for neuroprotection through several publications, and that particular to estrogen receptor alpha in breast, which we love because breast cancer is a concern for everyone. And we want to stay away from it. That's the end. So I'm happy to take questions now, and I'll open it up to our moderator.
Thank you very much. That was absolutely fascinating and answered my main question was, after Dr. Bove spoke, was what kind of research what has research shown us that is effective in treating people with MS based on studies of either pregnant women or menopausal or postmenopausal women, and I have the answer right there. So that's part of it. Perhaps either one of you can speak to other things that may have come out of these types of studies. I'm particularly interested in how these female hormones are so protective of people with MS or women with MS, and how do we translate that into future treatments for everybody with MS?
So I want to say one thing about that. They aren't all protective. I really underscore that if you look at birth control pills, that's been looked at quite a bit. And so birth control pills, do they have an effect on MS? And the answer is that no, they don't. They've been looked at retrospectively. They've been looked at a variety of papers, and some of those studies, again, estradiol, some of them had one progesterone, some had a different one, some had progesterone only. There are all kinds of flaws with those studies. They were low doses and they do not work. And so this is not easy. We've got to pay attention to what I was saying, which you've got to get the right estrogen type. And by and large, the answer is absolutely not. Birth control pills have not been shown to be protective in MS, so they are not. So that's one thing I just really want to emphasize, that it's not easy and it's not good enough just to say, oh, well, birth control, anything's going to work. It's not going to work. So you have to really make an effort to identify the dose, timing, and mechanism, or it won't work. But it makes sense. If you think about interferons, we know a lot about interferons. There's interferon alpha, there's beta, the gamma. I mean, these things and there's doses. We all know that the MS field really does know this, don't they? It's nothing new that this is happening with the estrogen. Just throw them all in a bucket. We know actually the interferons from years ago were worse for MS. And then the gamma interferons, the alpha and beta came along and they're better for MS. We also know within the beta interferons that higher doses are better than lower doses. We know all this. And it's the same thing with the estrogens. They just need to be given the attention, rigor that the interferons have been given, and you will see an effect if you do it right.
Mm-hmm. One thing I'd like to add as well is, thanks so much, Dr. Voskuhl, for that wonderful talk. And I am getting a little delay, so if you are as well, please let me know. But the one thing I'd like to add as well is just the experience of women with MS during the menopausal transition. So Dr. Voskuhl did this beautiful job of talking about the hormones in terms of their potential for neuroprotection, for repair, for disease progression, etc. What we also have during the menopausal transition is just an exacerbation of symptoms that comes when the hormones are a little haywire. The FSH is rising, the AMH is low, the estradiol's kind of, all over the place. And people in the general population, as Dr. Voskuhl explained, get cognitive difficulties, but they also get mood difficulties, hot flashes, sleep disturbance, pain, etc. And our people with MS commonly during that time period really feel like everything feels worse. So all of those symptoms and then the hot flashes kind of just contribute to, we know that heat is bothersome in MS, and the hot flashes really do sort of their damage as well. And so regardless of whether or not someone is thinking about HRT in the realm of neuroprotection, we also need to just kind of simmer down all of the symptoms that are happening during the perimenopause so that people feel better. Because we know that if people aren't sleeping, if we know that they're feeling more anxious, more upset, if we know that their bladder function is worsening, their general wellness is going to drop, and it's all going to be a vicious cycle. And so whether or not people are thinking about sort of protecting the brain for longer term, I think there's also a really important argument to be made to just kind of improving quality of life and reducing all those midlife risk factors, risk for diabetes, risk for high blood pressure, all these kinds of things that we know feed into risk of cognitive changes long term. And so during the midlife, I really like to warn my patients starting at around age 45 that you may start having the symptoms of menopause. You may start, it may creep up on you. I want you to be aware, because I don't want you to look back and say, what happened? I want to just work through the symptoms one at a time. We'll kind of, see you more frequently. We'll think about comprehensive care so that we can actually really try to get people feeling better, sleeping better, thinking better. And then that will in turn set them up for better sort of healthy aging and just reducing all the other medical things that happen at midlife when people don't feel well. And so I think that's another important piece here. And of course, hormone therapy plays a role, because hormone therapy, when given at the right time, reduces the risk of diabetes. It reduces the risk of many cancers, actually, and reduces the risk of all-cause mortality if it's given at the right time. But in addition to those things, it can also just help people feel better. So In the US, if people can't take hormone replacement therapy, they can take other medications that help the hot flashes. So in the US, there's an FDA-approved medication called fezolinetant or Veozah, and that does not work through estrogen at all, but it really just abrogates hot flashes entirely. There's also antidepressants, gabapentin, cognitive behavioral therapy, even hypnosis, all have an evidence basis to help the hot flashes and improve quality of life at menopause. So insofar as people just they feel bad and they commonly come in, I have patients who are stable for many years who come in just feeling worse, and we can actually, if that, as Dr. Voskuhl said, we can really do a lot to improve well-being. That is a goal in itself. And then also preventing long-term changes is another goal. And I think we need to really think about menopause comprehensively, both as the perimenopause and subsequent aging as well.
So to add to that,
Thank you.
what we're doing at the Comprehensive Menopause Care Program at UCLA is basically, they asked me if you're treating with estriol, the 2 milligram, the estriol, the designer one for, neuroprotection, would that help hot flashes? And I say, well, yes, it's been used in Europe for 40 years to help hot flashes. And so the answer is yes. And, but they can use, if they have them really, really bad and that's a primary concern, then they can go on the estradiol patch. That's usually what they use. And they're going to have to limit that for a few years at the lowest dose possible. But as Dr. Bove said, you can't treat people who've have a history of breast cancer. And you can't treat people who have contraindications to estrogens, period. You just can't. They've got breast cancer. You can't treat with really any estrogen. Also, if they've got a history of clotting disorders, you can't treat them. If they're likely to get clots, they can't be treated with estrogen. So that's when at UCLA, we come across with some of these non-estrogen containing treatments for some of these symptomatic treatments that, they just can't take estrogens if they've had a history of, breast cancer, ovarian cancer, uterine cancer, clotting. So it's the usual contraindications. So there has to be a place and a role for non-estrogens in those people particularly.
Okay, and that leads me to a couple of questions. One person has asked if they had their okay, let me just find the right question here about removal of their fallopian tubes. If they had the fallopian tubes removed before they went through 9 years of HRT, would that have saved their brain? If they had the fallopian tubes removed so that they could keep the ovary.
If you remove the fallopian tubes, it doesn't matter. What matters is the ovaries. And the GYNs now, it's really interesting to hear them talk, which I do all the time now, but think about it this way. There's obviously the ovary, the fallopian tube, and the uterus. And if you have the fallopian tubes removed, you still have that functioning ovary. So, in the really old days, women used to say, I'm done having kids. They used to have ovarectomy and hysterectomy, and the GYNs don't do it anymore because they realize leaving those ovaries there, they have a role. They have a protective role for brain, for bone, for breast, for various organ systems. That it's good to have some estrogen on board for a variety of circumstances. And so they tend to leave the ovaries these days, and they'll do hysterectomies without and the fallopian tubes are not an issue. It's whether the ovaries are present or absent that is the key.
I do want to also add to that, which is that if you are someone who has had your ovaries out, if you have had breast cancer and are treated with sort of a medication that reduces the estrogen, it may feel that hadn't happened, but we still have people functioning very well in those circumstances. And I think there are still a ton of things that we can do to maintain wellness. And so, as Dr. Voskuhl mentioned, things like breast cancer are very common, and they're going to be very common in our MS population. And yes, ideally, we would be able to optimize all the pathways of resilience, repair, and sort of neuroprotection, including through the hormonal pathways. But there's many other things we can do as well. And so I want to make sure that our listeners who, may have missed the boat on HRT or who may not be able to take it for whatever reason, still feel empowered to go and get really comprehensive management for their symptoms. As Dr. Voskuhl mentioned, there's many other things that we can do for patients. So it is a message for hope, even people who may have experienced sort of a medical, a contraindication to the hormones.
So one thing
Okay.
that we're doing along those lines specifically, just to add to that, is in this very specific circumstance that's been alluded to, but we probably should discuss it in a little bit more detail, is who have breast cancer are treated with tamoxifen. Tamoxifen blocks estrogen receptor alpha because, as I said, that's the reason everybody thinks estrogen receptor alpha is deleterious for breast cancers, because one of the treatments for it is tamoxifen because it blocks the ER alpha. And you might say, well, why would you do that if you take the ovaries out or you're menopausal? You don't have estrogen anymore. So why would you treat with tamoxifen to block ER alpha if you don't have estrogen anymore? The answer is because the adrenal gland makes a hormone that can be converted to estrogen, and estradiol can still bind that estrogen receptor alpha in breast, and that's why people take tamoxifen. Now, for cognition and neurodegeneration, it's important to note that women who are put on tamoxifen have cognitive issues, and we have a whole faculty person who sees those women who are put on tamoxifen for breast cancer and they have cognitive issues. They can't be treated with estrogen, of course, but as Dr. Beauvais said, what we do, they can be treated, and what we do with them, we do formal cognitive testing, and we have our neuropsychologist map exactly which cognitive domains are worse in these women who've been treated with tamoxifen, which blocks the ER alpha. We have cognitive testing done, and then they offer cognitive behavioral therapy. So they can do cognitive exercises which focus on those cognitive domains that they're having a problem with because of the tamoxifen. So I really can't say enough for physical therapy, cognitive therapy. I think that really in combination with hormonal therapy too would be ideal. I mean, one way to think of it is if you think about males, it's kind of easy there. So if you think about a male who's trying to he's a weightlifter, okay, for whatever reason. If you think about one that's taking testosterone, their muscles get bigger. The one over here is exercising, their muscles get bigger. Well, you know what? If they take testosterone and they exercise, their muscles really get bigger. And so it'd be nice to have hormones and it'd be nice to have exercise, cognitive or physical therapy. But if you can't have the hormones, you still need to do the therapy. The therapy is very good, both physical and exercise is very helpful. And they can be synergistic with those who can't have the hormones.
I think it needs to be a multi-pronged approach, basically, for
Yes.
just about any system. Yeah. Okay.
Yes.
On to a next question. Let's see. Is MS-related fatigue levels different for those who deliver naturally versus C-section? Dr.
That's
Beauvais,
a
I think
great
that might be your...
question. Yeah, that's a great question. We have some initial data that's so commonly people want to deliver vaginally, and some people kind of consider it sort of a bummer, a medical complication that they deliver by cesarean section. What we've seen in some of our patients, which is quite interesting, is people with MS are juggling so much in the postpartum period. Sometimes the C-section, like you can't really get up. You have to take medications for the pain. It's almost like you get a medical permission to just take things down a notch. And sometimes our patients feel a little bit better actually if they've had a C-section. So we're actually looking into that because it's not what we would have expected. Of course, the trauma of the operation and the recovery, that can take its own toll. But I think it underscores the fact that for everybody, the postpartum period is really complex. It depends what social support you have. It depends what time you have to rest and recuperate. Breastfeeding can be really tiring for people. And so sometimes that's also contributes to postpartum fatigue, and not everybody can do it for that reason. Similarly, cesarean sections for some people may be sort of upsetting, and for others may just be the permission they needed to just simmer down for a minute. So it is interesting.
Okay. On a related note, are fatigue levels, MS fatigue levels, different postpartum in breastfeeding versus bottle fed? And I would think that
I
it's
think,
probably related to what you just mentioned.
yeah, really similar. I mean, I think that the exclusive breastfeeding, sort of intensive breastfeeding, is really intensive, and people have severe sleep disturbance, and they just never have time where they can just rest for more than a few hours. And so sometimes, for some patients, being able to just plan to pump at scheduled intervals and then get 4 or 6 hour uninterrupted sleep time can be really, really helpful. So again, it sort of depends on what the patient's goals are and also sort of how the breastfeeding is going. I do think it's critical to get lactation support early. So anyone who's planning to breastfeed, is as much as sort of lactation is sort of part of being, mammals, and, should you'd think it would be an easy thing, it's often not. And so getting that support early can really make a difference and get patients on a good track there and minimize fatigue.
Having a coach doesn't hurt. Our next question, is there an increase in depression or anxiety in menopausal women with MS when compared to the general population?
Go ahead, Riley. Want to go ahead?
I think so. I see it frequently. I see
I think so.
people who've been doing well, again, just kind of fall off a cliff. That said, it's not a reason to despair, because we just need to manage it all. Just like in the postpartum period, just as in Shauna, sort of comprehensive care, so much of it can be improved if we're paying attention. Do you agree, Dr. Voskuhl?
Well, I think anxiety and depression are increased with menopause in non-MS women, and so I don't know. I just don't know if it's statistically significantly more in MS women. It's just very common in non-MS women. Menopause is very hard, on women for anxiety and depression.
Okay, when comparing women with MS experiencing menopause, is there a difference in disease progression and symptoms depending on the type of MS that they have?
So this brings up an important point, and that is what does menopause do to MS, and what does it not do? And in that regard, as Dr. Bove, kind of implied before, and I want to reemphasize it and add a point to it. What menopause does to MS women is that it makes their pre-existing disabilities worse. What it doesn't do is it doesn't prompt relapses. So we don't see menopausal women coming in and they're having a whole bunch of relapses, and therefore we need to escalate their anti-inflammatory DMTs. That's not the solution, is to escalate DMTs when their menopausal age and their disabilities are worsening. That's not the answer at all, because what's happening is not relapses. It is actually worsening of pre-existing disabilities, which of course is consistent with neurodegeneration, not more inflammation. And so the treatment needs to be neuroprotection, not escalation of anti-inflammatories.
Interesting. I never thought of it that way. A comment from from somebody on Facebook. They're saying, very interesting. Thank you for the information and discussion. Makes me feel a little less alone. And I would have to echo that. I had a fairly easy time through menopause, so I can't really complain about that. But learning all of this is absolutely fascinating, and I'm glad that there are so many people out there who have joined us tonight to find out about this. We've got time for one or two more questions here. Um, with regards to hormone replacement therapy for menopausal women with MS, does it help with bone health and cognition? And we've kind of answered that a little bit, but maybe you can go into a little bit more detail. I was wondering about bone health myself.
Yeah, I can answer that. So when I see people at UCLA, again, they see me. They also see the bone expert, which is really cool. I get to see what the bone person says. The bone person gets to see what I say about the brain. And so the classic, I can just tell you what the GYNs say for bone health. The DEXA, we're doing DEXA scans actually at age 50 to get a baseline. And I know that sounds outlandish to some people. We're doing everything preemptively, prophylactically. It's better to prevent than reverse, and repair is better to prevent damage. And so getting a DEXA scan at age 50 as a baseline and then repeating that every few years is extremely important. The treatments, as you know, these phosphate drugs that are given. Some people like them to improve bone density. Some people don't, because they actually, unlike estradiol, which is FDA approved for bone to protect against osteopenia and osteoporosis, it's estradiol, and it's very strong and powerful. And that's kind of good because it helps build bone, not just make the bone you have stronger. It can make it a little bit more, well, I don't say brittle, but it's not, doesn't build bone the way estradiol does. Estradiol, to be specific, is very good as a preventative for osteoporosis. Estriol is interesting. It's been given in Europe widely. There are some papers that say yes, it can also help with osteoporosis. There are some that haven't looked at that. What we're doing is when they really want to prioritize brain and they're also concerned about bone, we're going ahead with the estriol, but we're watching them with DEXA scans, maybe a little bit sooner intervals, to see if they're doing as good as they would have done if they would have got this really potent estradiol patch or not. We don't know yet in a head-to-head study whether it will be as potent or not. Some papers say that it can protect bone, but it hasn't really been well established yet, like it has been for estradiol, which is very clear that it's helpful. But again, you're not going to be able to take that longer than 3 years or 5 years at the lowest dose possible.
Okay, and somebody is curious about whether this estriol is available in Canada.
It's available. Yes, it is. Compounding pharmacies. Now, the problem is, it's just not. The beauty of what we're doing, honestly, is we've got a standardized national pharmacy, national way of doing things, keeping a registry of how people are doing. But yeah, compounding pharmacies can do it in Europe. They can do it in Canada. The problem is the dose and keeping track of everything, like what we're doing in the United States. The company hasn't moved into Canada yet, but I just don't like it because compounding pharmacies, there's all sorts. They do all different things. And so I believe in standardization. I believe in data collection. I believe in tracking. And so that's something that, we're doing in the United States and not in Canada yet. But we'd love to collaborate and work with Canada on some of this stuff. We really would. I'm actually also talking to the Europeans about it because the same thing needs to be done there.
Okay, so who would the menopausal woman go to get this drug? Like, would they go to see their GP, their neurologist, or their OBGYN, or all three of them?
I mean, well, I like for them to see a GYN and a neurologist. I mean, the GYN could be replaced by a family practice sort of a person, but I think it's important to see a neurologist and also either the GYN or a family practice, one internist, family practice, or GYN, one of those. And I do think a neurologist is good if they're concerned about brain health, because what I do, if you want to know what I do when I see them, I do the same thing with every single one. It's like, do they need an MRI or not? Is this beyond the realm of what you would expect to see with changes of menopause or not? Now with MS, it's more complicated. So the answer is probably yes for most of the MS ones. For non-MS, generally not, because it's just so classic what they're having. The second thing that we do, actually, that's kind of interesting, we haven't talked about, is we do ApoE genotype testing. It's a gene that's known to be involved in Alzheimer's disease risk, because people are worried about this. We offer formal cognitive testing with behavioral cognitive testing, and then I talk to them about what menopause is or isn't. I compare estradiol patch versus estriol. So that's kind of what we do. I think it's good to talk to a neurologist about those things.
Okay. Well, we've pretty much come to our end of time for our questions. So as we wrap up today's broadcast, we want to remind you about how you can connect with the MS Knowledge Network, which is staffed by trained navigators who provide consistent quality information and support. You can connect by phone, email, or live chat through the MS Canada website. Navigators are available Monday to Friday from 8 a.m. to 8 p.m. Eastern Time and can provide assistance in both English and French. We also want you to be a part of the MS community and encourage you to get involved with our programs, services, events, government relations, and/or volunteer opportunities. To find out how you can take action, check out our website at mscanada.ca. And if you have any questions about any of our education activities, you can reach out to the education team by email to education@mscanada.ca. I'd like to take a moment to thank Dr. Bove and Dr. Voskuhl for joining us today and giving us all this great information and insights into pregnancy and menopause among people with MS. So on behalf of MS Canada, thank you for tuning in to today's webinar. Have a good night.